Let me focus on one piece, and it deals with a strategy in Massachusetts for tackling costs as it relates to the recent Provider Payment Reform Commission around accountable care organizations. So the provider, all right, phase one in Massachusetts was what can we do to get everyone under the umbrella of covered for insurance? And I think we've been very successful, and I would tell you that I think that our state and our leaders really followed a model path for getting people covered and setting up our population in three buckets. Those that can afford care and should get it, those that can't and society should help, and those somewhere in the middle where we have a progressive approach to helping those individuals pay for the insurance that they're required to get. A lot of other details there, but I think that was rather simple and powerful. Now, phase two, as Jim says, is how do we get control of the underlying medical cost trends? Because that's what's driving the insurance costs up. If you all have been keeping a close eye on how we're all doing financially, you'll know there's an awful lot of red ink right now for a lot of different reasons. The rest of the United States, there may be other trends going on, but here in Massachusetts, that's not the case. Well, phase two of healthcare reform, one of the key elements of there was to create this commission of individuals, of experts in all different walks of health insurance and healthcare policy arenas, and come up with a recommendation for changing how we approach reimbursement and payment for healthcare. The key recommendation that came out of this commission is to create accountable care organizations. Now, the definition of what really is an accountable care organization is still fairly nebulous, and I think that's kind of good because one size doesn't fit all when it comes to how providers should come together and work together to care for a population of individuals. But the idea behind this commission was to create groups of providers, hospitals, physicians, other healthcare providers that would take some sort of a global payment risk to care for the individuals that they're being paid to care for. And we need to move the market, Massachusetts, to full accountable care organization or something very close to that within about 5 years. And furthermore, because we like regulation and we like to create new functions, and often overlapping in Massachusetts, let's also create a panel of experts that would oversee the payers and the accountable care organizations to make sure that we're negotiating contracts properly, that we're distributing risk properly, that we're doing this on a timely basis, and the list goes on and on and on. And you know, just imagine how many ACOs there are, or there could be in Massachusetts. Multiply that times the number of payers negotiating contracts with those ACOs, and these are complicated negotiations that are going to differ depending on market share, information availability, and this panel of experts in Boston is going to oversee and make sure we're doing it right. Well, you know my opinion on that. That is absolute craziness. Customers and you as individuals need to keep in mind. One is the impact on the individual member. Members are so used in the last 10 years of having lots of choice. We moved away from the group model strategy years ago because we didn't want to be held to one group of doctors or one hospital. We wanted to go wherever we wanted to go when we felt we needed it for the same copay. When you're in an accountable care organization as an individual, you're going to be managed by those groups of physicians in that hospital. And if you want to leave that organization, that group of doctors, the doctors are going to try to keep you in because they have the funds to care for you. And if you want to go out and see a specialist outside of that ACO, those doctors are going to have to take their capitation, if you want to call it that, and pay those doctors for the services outside. And the doctors don't realize this, many of them don't, that are in the day-to-day trenches, because they're going to be put in a position of having to say to the patient, no, you can't. Their administration is telling them, keep the patient in. We don't want these purchase services outside going up. And it puts the doctor in a very difficult spot of having to say no. They don't like to do that. I understand that. So what will they do in many cases? They'll say, I'm sorry, you can't go there. Your insurance company won't allow you to go there. You know, go from, these guys only have 10 minutes to see a patient, so make it simple, patients understand it, and this does happen. And the challenge here is not so much that we don't have a good mechanism for controlling costs, but we're now creating a new degree of tensions that are going to build up. And these tensions will be much worse if we don't take more time up front with a lot of education. It has created reactions in the provider community that I've not seen since I've been here now 10 years. Providers interested in sitting down with us and talking about risk. How can we establish a new relationship? You know, and it's actually, that's very good. That's very good news for us all. So stay tuned on that. And as Jim said earlier, what we need to do, and Alan Enthoven at Stanford had a recent paper out, is we do need to find ways to bring incentives together, especially at the patient and the physician level, through benefit plan design and through provider payment design. You can't do just one, you have to do them both, and that's the real nut to crack. Unfortunately, so far I haven't seen our leadership with a strong enough spine in Washington, D.C. to stand up and talk about the tough stuff, because it won't get them reelected, but that really has to happen. I don't see it happening this time, though, with federal health care reform, but we're on our way here in Mass. Thanks.
Thank you, Art.